In this video, we will discuss the history of ART scale-up globally and describe what PrEP is and why it's significant in the fight against HIV. Finally, we'll talk about some of the challenges of ART adherence. The history of ART scale-up is important to retell briefly. Research on ART was cited as a breakthrough of the year in the 2011 by Science magazine. It showed that antiretroviral treatment, if people are adherent, actually knocks the viral load down in people's bloodstream so dramatically that they are far less likely to transmit the virus to anyone else. So if you're on ART, you're not going to be very infectious. In fact, you might not ever transmit your virus to someone else if you are adhering to your drugs. Clinical trials finally showed that this is actually the case, and that meant that antiretroviral treatment was also prevention. It meant the more people you get onto treatment, the more likely it is that you're going to stop the transmission and the growth of new cases, and you can stem the tide of the epidemic. So that added impetus to get more and more people onto antiretroviral treatment as fast as possible. There is also something called pre-exposure prophylaxis, or PrEP, P-R-E-P. People who are in a relationship where one partner is HIV negative and the other is HIV positive are called serodiscordant couples. The partner who is HIV negative can take an ARV called tenofovir to prevent infection. And if they take that pill, they can have a sexual relationship with their infected partner and protect themselves from getting infected. That's very important for everyone, but has very special resonance for couples who would like to have children where one partner is positive and the other is negative. The combination of the pre-exposure prophylaxis for the HIV negative person and ART for the HIV positive person in the couple almost eliminates transmission. If you can get both people taking these medications, we can stop the transmission of HIV, in principle. This has been scaled up around the United States. While less successful in Africa, progress is being made. Hopefully, we'll be able to get PrEP available for all people who need it to protect themselves from getting infected. Jared Baton, right here at the University of Washington, led some of the very core critical work and big PrEP clinical trials in Africa. In principle, we have the tools to actually stop the growth of the epidemic and then treat everyone who has it, if we could get everyone onto these drugs. By 2015, as a result of much of this research, it was decided by the World Health Organization that as soon as someone tests HIV positive, they should start antiretroviral treatments for themselves, but also so that they don't transmit it to other people. And hopefully, in the long term, that will also keep them healthy over time. It used to be that you would only start antiretroviral treatment if your CD4 count had gone very low, your immune system had really deteriorated, or you might have started showing the signs and symptoms of AIDS. But you wouldn't start the drug therapy before that. But now WHO promotes test and treat. Start people on ART as soon as they test positive for HIV. However, adherence is important because if you're going to keep the viral load down, you need to be adherent. If the medicine is going to work, people have to take it every day. Now, you might miss a day here and miss a day there, but you need to be taking it over 90% of the time. You've got to make sure that you're keeping those drugs in your system. There are a lot of ARV adherence challenges, especially in poor countries. First, there's the problem of stigma. People have to go to a pharmacy to pick up their drugs, and they might not want other people to know that they're HIV positive. As a result, they might avoid doing that. They might also have other things going on in their lives that seem more important than possibly disclosing their HIV status. There are also, unfortunately, some drug side effects that can make people feel nauseous or can make people feel very poorly. And if they were otherwise healthy and they start taking these antiretroviral drugs that start to make them feel not so good, they might stop taking them. Lack of food is another big problem. It's very hard to take antiretrovirals if you don't have enough food. There's a book and article written by an anthropology colleague, Ippolitos Kalafanos, on hunger among AIDS patients in Mozambique. This is a quote from an AIDS patient in Mozambique. Quote, "All I eat is ARVs." In other words, the only thing they have to eat are the AIDS medicines that they're too poor to have food. They may have lost their job because they are HIV positive. So this is a reminder that just providing drugs doesn't account for the wider social context of HIV. People get depressed for a variety of reasons, but especially if you're HIV positive, you might be depressed for very specific reasons related to HIV. Being depressed can lead people not going to health services, not getting care, not following through. Distance and transport are huge challenges in many poorer countries. People need to pay money to take a bus, or they have to walk 20 kilometers to refill their AIDS medicines. That's a problem. People move around. How do they make sure they continue to access drugs from new pharmacies if they move from community to community? And in very poor countries, there are problems with drug stockouts where health systems are not adequately funded and supported. The flow of drugs may run out from time to time. There's also poor treatment by health workers, which is another factor that might prevent people from coming back and staying on their medication. So there are a lot of challenges around adherence. We will continue to discuss these challenges and more recent goals established to expand treatment access.